Marathon. This truly is a unique event, and over the next 24 hours, we will be traveling around the world to hear from leading experts and surgeons. We will be looking at live surgeries, discussions, and real patient cases. I'm Chantal Pretorius. I'm an international model from South Africa, and about 3 years ago, EYECRYL Phakic truly changed my life, both personally and professionally. The person who introduced me to EYECRYL Phakic is Carlos Rios from Biotech. Carlos, it's so nice to see you again.
World Marathon. It's always a pleasure to have you with us. And now I'm now switching into Spanish for our local audience. For all who are watching us from other countries, don't worry at all. All the session is going to be translated, simultaneously translated into English. Bienvenidos a todos al EYECRYL Phakic World Marathon.
Everyone to the EYECRYL Phakic Marathon. It is an event that we are very excited to celebrate with you. We're really excited, really happy to go around the world in just 24 hours, connecting with customers from 4 continents and 14 countries. This is an event which technically is very complex. So first of all, we are sorry for the delay. We had some technical challenges that we were able to solve. And however, we did have to change the schedule a little bit, and we will continue to do some adjustments throughout the event. But let me first introduce the story behind EYECRYL. EYECRYL Phakic was registered, was patented 12 years ago, which is time enough to prove a lot of things. Apart from this, we will talk about quality since the creation of EYECRYL Phakic. Apart from proving high standards, the highest standards, it also implied something no one has complained about, which is breaking the status quo, the monopoly. Everybody is happy to break this monopoly. Also, we are talking about an expansion of EYECRYL Phakic, which has tried to put the service of everyone and the access to technology as globally and easily as possible. This expansion and our ophthalmologic approach follows our motto, which is access to innovation. For the last 12 years, we've been trying to provide everyone with the best versatility and quality that can be bought around the world. And we had a keynote given by myself with the new launches and the next steps, and with how we see EYECRYL Phakic in the future. I am the global head of the division, and this is why I will have the pleasure to explain many details about the calculator, about purity, technical details. But we will see these later. First, we'll start with the scientific program, and then I'll give my keynote. First, we have Dr. Marc Carbonell from Instituto Castanera. This organization is very familiar to me, as the Clínica Barraquer in Barcelona is as well for me. Well, we decided to organize this event. Instituto Castanera is familiar to me because I spent some of my professional career. I spent 8 years there, and specifically with Dr. Carbonell, we started the new calculator. It was his initiative, the initiative by this institute, and Dr. Carbonell will give us data about the results, about his experience for the last 4 years of follow-up with several patients. So it's 4 years of continuous implants. So we will have Mr. Carbonell to explain, to share his experience with us. Good afternoon. I would like to thank Biotech and Carlos for inviting me to talk in this Congress, and Clínica Barraquer for hosting us. Today I will present the study we are carrying out at Instituto Cabanás after 4 years of the first implants of EYECRYL Phakic lens with the calculator, the prediction of the volt. As Carlos mentioned, we started this project. Regarding the design of the lens, it has a familiar design with a central port, 360 microns, and an effective optic zone of 6.5 millimeters. The central port is also present in hypermetropic lenses, so we don't need iridotomy, and we can vertically rotate the lens without obstructing the flow of the aqueous fluids through the iridotomy. This is the pre-op protocol at Instituto Castanera. We use a series and white to white. It's integrated in the calculator. We continue to use ORB scan. We introduced this as well in the calculator. As biometer, we use IMaster 700, and we have 2 OCPs with which we integrate ATA and CLR, especially Visanti, and we are also introducing data with zero. It's a sample of 209 eyes, average age 29 years, and 5.05 pre-op diopters. These are the details of the sample and the methodology. Regarding the efficacy and safety, in this slide we can observe that phakic lenses have a high rate of efficacy and safety, and the results with EYECRYL Phakic lens are leading the results compared to other lenses of the competition. Regarding the spherical equivalent, here you can see the 3-year follow-up results, at least 3 years, and the refractive stability is preserved. There's mild accommodation, especially in young patients, around a quarter or half diopter, especially young patients, as I said, that can have aberrations that can affect nocturnal vision, night vision, and this residual can compensate, and as a reserve in case there is an increase in the short-sightedness. In case of myopes with symptoms of presbyopia, this can be we always leave a negative residual without compromising the general vision. We just found 1 rotation in all the samples following the manufacturer's recommendations. None of the lenses had an adjustment higher than 15 degrees in relation to the implantation axis. This was just an early case. It was repositioned with a light repositioning, and after 1 year of follow-up, no movement has been observed. So the design has an excellent rotational stability, and in the sizing of the lens offered by the calculator, this encourages to implant a high percentage of toric lenses, even half a diopter in power. The endothelial health is preserved in both in the pre-op and the yearly follow-up, with a loss of 18 cells, which is not clinically or statistically relevant. And we haven't found any correlation between the post-op volt and the endothelial variation. After 3 years, no sign of crystalline opaqueness. This is especially relevant in some cases, especially at the beginning when we had a low volt, but we haven't had any degree of opacity, sorry. This talks about the posterior safety, good protection of the crystalline lens in the long term. Opposite to what we might think, the white-to-white is very reproducible, replicable, in many cases comparable to ATA. When we introduce 3 white-to-white measurements, we reduce the error and we increase the safety of the white-to-white. Another way to prove this consistency between the pre-op volt, the predicted volt, and the real one is this graph, where we see a high consistency and correlation between the pre-op and the real volt. But most interestingly, we found high reliability. Integrating these 4 measurements, we achieve a high predictability of the results. Here you can see a comparison of the Biotech formula with other formulas, and within the groups of 100, 200, and 300 microns, the Biotech algorithm have very competitive results compared to other formulas, especially guided by OCT or UVM, where only the Dr. Reinstein formula and the London Vision Clinic shows slightly better results in the 100 and 200 micron groups. If we analyze by groups, we see that 49% of the patients was between 100 microns of the prediction, 82% 200, and 96 300, within 300 microns. Since we've been using Biotech monogram in our institute, and since then, based on OCT Visante, it implies a refinement of it's a reference of safety and previsibility for surgeons globally. This platform has shown long-term stability, at least 3 years in our series of data, with almost no rotation, is only 0.48. This, I would like to highlight also this multi-device factor, which allows us to reduce variability, anatomic variability. And finally, the nomogram, the Biotech nomogram, leads clinical precision compared to standard international formula. Thank you. I have a question for you. You mentioned cases with low volt that you had at the beginning. What would be your lower limits according to your experience before planning to change the lens? Did you change the lens? The minimum was 70 micron. We've done a follow-up. This was one of the initial cases, and there hasn't been any change in any of the exams we've performed. So I couldn't tell you what's the lower limit. What was the age of this patient? I think it was 35. I'm saying this because oftentimes with nothing happens with a low volt, but the crystalline lens grows. So maybe if she was 23, maybe I would have considered changing the lens. So what is the first lesson? This was your first lesson. When did you start considering as a surgeon to trust this new technology and this new lens? And when did you feel confident enough to use it? It was really early in the process. I think I hadn't implanted many ICLs, but at the time, and the confidence during the assembly and the insertion, and when we had the first version of the calculator with the precision, the high precision in calculating the volt, this gave me a lot of peace of mind. So this is what convinced you. Yeah, the volt sizing calculation, because this is a headache when you want to implant a phakic lens. And I'm really confident. I have complete peace of mind with the calculator. You mentioned that you didn't have a lot of experience with ICLs. When you started using EYECRYL, was it easy to change? Well, I had performed 100 ICLs. Well, that's a lot. Well, we've done many more EYECRYL, so. Any questions? What about yourselves? What is the minimum volt? Am I allowed to ask them? When would you consider changing an EYECRYL or a phakic lens in general? In my opinion, a low volt to me I would change it because there's a reduction of the volts, or because we don't have but I don't have a specific figure I could tell you. With hypervolt, I would consider changing it. We've lost the sound from the speaker. We cannot hear the microphone. We cannot hear the microphone. I think this lens is different compared to others because the volt is more stable. I think we will talk about this later. We don't see a reduction of the volt throughout the years. According to my experience, we haven't had to change any lenses. We want to see the evolution. Obviously, talking to the patients, if we see an increase in the crystalline, then we can consider changing the lens. But so far, we haven't changed any lens, and we don't consider changing it, even if it's a little less than 100. We have some questions over here. They're asking. This is a classical question. This is a question for Dr. Marc Carbonell. When switching from ICL to EYECRYL, did you see a huge difference in the handling of the lens? The rigidity everybody's talking about was a problem or rather an advantage? Well, there's a change. If you're used to handling ICLs, the lens is softer, and EYECRYL is a bit more rigid. You can feel the difference, but it's not a problem. The advantage of the rigidity is when you implant toric lenses, because if you do it right, then you can rotate the lens on the iris in the final, almost in the final position, and then we implant the lens in the sulcus. If you do this and you place it correctly, when you aspirate the viscoelastic, there's no rotation. You don't need to touch the lens anymore. And for me, this is an advantage. Any other questions? There's another question. I think we have time. What's your experience with EYECRYL Phakic? Did you have any hypervolt or low volt problems? What's your experience with EYECRYL? Have you had many cases with low volt or with a hypervolt? So what is the trend? I think this is the question. Since we got the calculator, we've had just a bunch of cases, but we haven't had hypervolts or low volts. It was just at the beginning, and it was only low volts. But after that, we haven't had any cases. The trend in my case is going low. In this respect, I prefer low volts, but we haven't had any problems. Thank you, Dr. Carbonell, for your collaboration. Let's move on to the first live surgery with Dr. Lamarca. Let's see if they are ready. Dr. Lamarca, are you there? Are you
Espera,
ready?
parla ja que no et sentim res.
Please bear with us.
Bueno, aviseu-me i ja comencem a xerrar.
Dr. Lamarca has provided a lot of guidance and information.
Sí,
Thanks to him, we've been
Cuando
able to
digáis.
advance a lot, thanks to his help to
Sí.
develop the calculator. After when he comes back from the OR, I think he's ready right now. We have him online. Dr. Lamarca, please go ahead.
Hola, bienvenidos todos. Estamos en el
Welcome.
quirófano del Centro de Oftalmología
This is the
Barraquer
OR
y
of
vamos
the
a
Barraquer
operar
Clinic.
un paciente.
We're going
Está
to
prevista una lente 12.5 de diámetro, menos 7.
operate a patient. We have a 12.5 lens. We've done one of the eyes last Monday with a volt of around 300 microns. The eye we're going to intervene right now has a CLR of 0.45. According to the Nakamura formula, we're around 330 microns. The KS indicates also 340 microns. We're going to start. Please open both eyes. We use pre-vulvar anesthesia to block the eye and for comfort as well of the patient. We are interested that the patient are calm, and with the right sedation, we can have the best post-op for the patients. First, we're going to prepare the lens. As you can see, is contained in this little flask. the position is the correct one, and we just have to open the cap of the vial. And you can remove the whole thing. In some cases, nurses can give us the lens to us, and this saves time, but it doesn't really matter because it's a quick process. The lens has the classic phakic lens shape, and we're going to place it in the injector. On the tip, we want to put some viscoelastic, as well as in the rails. My colleague is doing it. We have to check the shape. We place it here because we know that the lens is going to unfold as a book. And one of the tips I would like to share with you is that in both sides we have this rail, this guide for the haptics, and this is what we need to do. We need to put them there. The lens moves a little bit, so we have to make sure that the lens is in the right position. Right now, we can see whether or not the haptics are in the right position, and we can use the tweezers to close it so that the haptics are not located or trapped in the flaps. This is the injector, and you just have to place it in it. Here, we just have to check that the lens is not clamped. And now we're going to check the mobility. The mobility is very good. If we see that there is any obstructions, we need to stop and make sure that everything is in place. The lens comes out uniformly, normally from both sides, so this would be correct. We're going to adjust the camera so that you can see it perfectly. We are using a Zeiss microscope. This will help us when checking the volt. We have an axon pincers. Let's clean everything around the eye. Since it is a toric lens, let's go into mark it. I'm going to zoom in. The microscope allows us to make a capture. And now we are capturing using the Callisto system. And here, for safety reasons, we're going to place two marks, one for the incision. We normally try to enter through the more curved meridian, which coincides with the incision. And at the same time, we mark the holes. In some cases, if I see there are going to be any problems, I only mark the holes. But the best is to use the marks you have on the lens. We use two-hand surgery, we use cannulas, and this is why we do both paracentesis. And one of the issues or factors that I think are more important are the iris dilation, especially with this lens. For a specific reason, we need to be comfortable when we work with a lens, and this lens is more rigid. And at the end of the day, this could imply some cell issues if we press a lot. And if the iris is completely dilated, it's going to be easier for us. We have placed some free drain, and now we are waiting. I close the eye, so there's less light on the eye, and the dilation is quite acceptable now. We clean, we rinse a little bit. We apply some gel to work in the best conditions so that you can see everything perfectly as well. And now we are going to use Violon, which is a cohesive. We're going to increase the chamber. We're going to access the chamber. The pupil will be in the best conditions now. To have the correct incision, I was thinking that it is important to have the eyeball with under certain pressure. It's a thin cut, a line, and we perform the incision. In some cases, I don't think this is the case, but sometimes if we feel comfortable with it, we can open a little bit further and create a trapezoid shape structure so that the access is perfect from both sides. Let's rinse the blood, please. Thank you. And now we can inject. I'm doing it slowly so that you can see it. It's a simple process, to be honest. You just have to be careful and work carefully. Now we're going to position the lens. I don't think we're going to lose a lot of viscoelastic because there's enough chamber. And here we can start to rotate the lens, trying to place the haptic in the correct position. I think the rotation movement and star ICLs is not recommended, but here it is useful to achieve the correct position. And here, if you pay attention, what we've tried is to basically place the lens in the best position so that it will perform as best as possible regarding the lens positioning, as we will explain later during the event. I think the lens is well placed now. I'm going to move this side a little bit. I like it better now. I think it is correct now. You cannot see it now, but we are checking the volts In this case, it is around 200 microns, approximately, according to what the OCT is telling me. So the result is correct. And it is just like the other eye. Now to remove the viscoelastic, since we used a cohesive, we could do it manually. We use cannulae in many cases. That's right. I think I was too optimistic. Yes, a little bit. All right. Can you rinse, please? There's an eyelash. And let's see if I can. These things happen when you are live. So I'm going to try the other side now. There we go. We increase the chamber, the pressure, and the entrance will be easier. Now I get closer to the hole, and this should be enough. Normally, we're not going to press the lens, but the post-op without the viscoelastic is normally much better, obviously. Very well, we can hydrate the paracentesis and we can consider the intervention is finished. The patients during the first week will wear or use a corticoid, dexamethasone with antibiotics, and hypotension medication. I don't think it's required. We could just use the corticoid because we are going to place the zerofoxima and we have removed the viscoelastic, so we shouldn't expect any problems. I removed the pressure from the chamber and now I'm going to inject cefuroxime 0.1. The pressure is correct. And it's been a pleasure sharing this operation with you. Everything went well, and I'll see you in a minute in person. Very well. We're done. Everything went very well. We will see you later here in the room. Thank you for this operation, this live operation, this live surgery. We're very close from the OR, and we'll have some time for questions. We continue with our program, with the scientific program. We have Dr. Cabanás to present her experience of all the surgeons of the Baviera group that have started using this lens, using the EYECRYL Phakic lens. She will explain. Dr. Cabanás, she's the medical director of Virgen del Rocío Hospital, and she's a specialist in refractive surgery. He has a long history in the Baviera group of clinics, and she is specialized in refractive surgery in Sevilla. Good afternoon.
Well, thank you very much for having invited me. I'm going to share the results of Clínica Baviera. They are not my individual results. It's the results of 132 eyes, 132 eyes and 166 patients. The average age 30 years old. So we have used these statistical models that will prevent the bias, and it is going to be more exact, the result of the sample. So having a wide range of lenses allows us to adapt the different lenses accordingly. We've seen a difference. We've seen that the most used size is 13 millimeters. If we correlate it with the refractive effect, we see that the most common combination is to use 13 millimeters lenses in moderate myopia. And it has been a combination that we have used in 30% of the total of cases. And all the groups, hypermetropic, myopic, but the extreme or high myopic, where the sizing was bigger, 13 millimeters has been the size of lens that we have used more commonly. If we analyze the total volume, as I was saying, it has been this size, 13, that allows us to cover all the different myopic patients. So if we check the non-corrected visual acuity, in 90% of the patients that we have obtained with security and efficacy index of more than 1. And it has been a spectacular, the improvement in acuity. And it's a very interesting with with an average residual sphere of 0.195 and an average residual cylinder of 0.393. So 89% of the eyes are in a strict range of 0.5 and 98% in an expanded range of 1 diopter. So the refractive result is very good. If we analyze the different groups, we see that the spheric equivalent is very low, adjusting to the group in which we use the lenses, moderate myopia, and perfect calibration of nomogram with reaching a situation of metropy. So no problem at all. And if we see the visual acuity vis-a-vis the different segments in refraction defects, we see that we achieve very high values in all of them. So it is a very consistent, even in more difficult cases. We can mention here, as we would expect, that in extreme myopia, we have a lowest uncorrected acuity because the target was a myopic patient. But not only is the visual acuity and the refractive results. It's also the security and the tolerance of the lens, the physical tolerance, and we are going to determine this with the volt, the prediction of the volt, and what we have obtained. 81% of the patients, of the eyes that we have analyzed, will be in an optimal volt between 250 and 750 microns. That will show that the lens has a very safe behavior. Over 10%, 12% of the eyes had a low volt, and these are the ones that do not concern us. And possibly 7%, we obtained a high volt of more than 700 microns. Sometimes this level is volt is conditioned by the lens rise and not by the lens reaching the endothelium. We have also seen that this volt is not modified depending on the eye being right or left. So the implant has a bilateral adaptation that is very consistent. And if we analyze the different groups of refraction defects in the hypermetropic, the volt is a little bit higher. So I think we can still increase the results, but we only have a sample of 15 patients, but maybe we could adjust it a little bit. But in the other groups of refraction effects, the volt is kept in a stable way in around 450 micron. This means that the productivity is very good. And also with the groups of the visual acuity, non-corrected and with correction, we see the good correlation in the groups of moderate myopia and in the low myopia, reaching visual acuity that are wonderful, very close to 100% with correction and 0.95 without correction. And I just wanted to show you how this volt is adjusted depending on the graduation and how it is correlated with the sizes that we have used. In higher myopia, between 12 and 13 in all the cases, and with a higher variability in the other groups that we have studied. We have also seen that the depth of the anterior chamber shows the behavior of the implant in a very significant way with a correlation validated by a model. So in order to conclude with these lenses, we have obtained an exceptional result, exceptional visual acuity with the gain of acuity after the operation of more than the corrected cases in 90% of the cohort. And we have a refractive consistency with residual spheric equivalents that are optimal and in a consistent way, with 98% of precision in ±1 diopter, and with a liability of the anatomy that is absolute, with 81% of volt predictive independently from the site, the eye that was operated. That was all. Thank you very much. Thank you very much, Dr. Cabanás. Now we give the floor to Dr. Antonio Tirado from Malaga, from the Tirado Hospital. He will share his experience after 1.5 years and a significant sample, and he will show a near-life surgery, and he will do it straight away. Dr. Tirado, thank you very much for your collaboration.
Hola, buenas tardes. Soy el doctor Tirado. Desde aquí, desde Málaga, pues os voy
Hello,
a
I am
compartir mi
Dr. Tirado.
experiencia
I'm going
con
to
las
share my
lentes fáquicas
experience
EYECRYL
with the
y
phakic
agradezco en
lenses,
primer lugar
EYECRYL. Thank you, first of
al
all,
laboratorio Biotech Iberia que
to
me
the
permita estar en
Biotech
este foro de
Iberia
EYECRYL
lab
Phakic
for
World
having
Marathon
invited me
para
in
contaros
this
mis
marathon
primeros
to
casos, lo que me
share
gusta
my
más y lo que me
first
gusta menos de las
cases,
lentes
what I
fáquicas.
like the most and what I like the
Bueno, pues yo
least
llevo
of
más de
these
20
phakic
años poniendo lentes
lenses. So
fáquicas,
I've
concretamente las
been
lentes STAR.
implanting phakic lenses, the STAR lenses, for more than 20 years. We were pioneers in Malaga 24 years ago in planting the first phakic lenses. And I've had very good results, some scarce as well. But I'm very thankful to the lab star and Alicia Aboyo, the commercial, who has always given us their support. So no conflict of interest with Biotech or Star Labs. And I'm going to show my analysis based on my experience of these past years and the last months with EYECRYL lenses. Thanks to Carlos Rios for his support and his help in the introduction of the of this phakic lenses. Why did I decide to use this lens? Well, we are talking about doing surgery in young people, myopic normally, but young people, and we need to look for the safety and to stop the surprises and preventing the replacements, because it can have a negative impact on the health of a young patient. And I've been listening to Dr. Ramon Ruiz Mesa or Dr. Paredes or everybody talking about the good aspects of EYECRYL Phakic lens, and also that have included a calculator of the bolus in the injector, and also the different sizes available. And the surgical implantation was very user-friendly. I decided to give it a try. And in October 2024, I have implanted 82 lenses, 52 of them are toric, so 65% of my lenses. And I didn't have to do any explantations during the last months. All my implants have been bilateral, but a few of them. And when I was sure, I started implanting bilateral cases. And with an ACA of 280 and some special cases like a friend's wife, the maximum is of 4 diopters. And also hypermetropic of 9 diopters with a cylinder of 3.5 with an AKI of more than 2.8. I'm going to share some things to give you a context. And it is similar to the standard ICL. And with a central port, which is important for the aqueous flow, but it is also present in the hypermetropic lenses. And the ICLs do not have a central port. And the with this type of lenses, we do not have to do an iridotomy. The orientation hole is in the left side, in the ICLs is in the right side. And as you can see, the different two positions, this has to be taken into account to prevent putting a lens upside down. As for the dioptric range, it is wider. It is just another advantage. And up to 10, up to 25 diopters, it is 5.5. And when it is more than 17 diopters, the optic area is of less. So we have 120, 125, 130, 135. But we can get up to 110 and 115 and 140, but the powers are more extreme. So we have a wide range, a very interesting range. And we have the mark of the toric lens, and it's a difference of 5 degrees and 5 degrees. Another important aspect of these toric lenses is that they are more rigid and they will stay where you put them. They don't rotate. So the iris cannot mobilize it, and it sets very comfortably. And as for the material, purified hydrophilic Ventec material 26 from Biotech lab, no pork, with a durability of more than 40 years, as the lab said. But as I was saying, it is more rigid and it is an advantage. So this makes the lens to be easily folded, and the implant and the injection are very user-friendly. So it is practically impossible to have a rotation of the lens. So vis-a-vis the ICL, that it is more difficult to implant and we have to rotate it so that it does not turn around, this lens is ideal for young surgeons. As for the pre-op planning, it is the same one as the ICL, the graduation, and all the different tests that we need to measure. We have topographies with a pentacam, the ACA, all the measurements are introduced in the calculator, which makes the surgery very safe. And what makes the calculator special is that it includes a volt predictor. So we can do simulations with different sizes with a predictive value of the volt. And the predictability is of approximately 50 microns. And it allows us to introduce a key wide-to-wide data. And we are going to incorporate in the Pentagon and MSc 59 the former one. And here you can see the lens and the rotation that we need to do. Very easy to do. As for the surgery, I wanted to give you some details and surgical tips. When I operate a patient with a phakic lens, I always say that first of all, I operate on the lens, I fold the lens, and then I introduce the patient into the theater so that the patient is not in the theater for a very long time. Because when I folded the ICL lens, sometimes I had to give a few tries until it was correctly introduced in the injector. And I will give you some videos so that you can see how easy it is taking into account the procedure. We introduce a cohesive viscoelastic. We open up, we remove the lens. We introduce it. The music is louder than the voice of the surgeon. We are doing our best from the interpreters. And we tutorize the folding. We close. This is what we see. We introduce it in the injector. And now with the tip, we see how the lens stays inside correctly folded. As you can see, it is really easy. As for the implant, we do it with anesthesia, like other phakic lenses. So peribulbar barotopic anesthesia, 3 millimeters incision, 2 paracentesis, and with the 2 spatulas ready, just in case the lens is rotated. And this lens, as I was saying, it is it does not rotate, so I only do 1 paracentesis with some cohesive disc and methicellulose. It is very easy to implant. It will not rotate. You will see it on the video that when we do an irrigation or an aspiration, the lens will stay. We use acetylcholine, cefuroxime, and I don't hydrate the incision. You will see some videos. They are a little long, so I am sorry for that. It is an implant of an EYECRYL lens, a toric lens. We are doing 2 paracentesis here. The sound of the video is very loud. The speaker is complaining about it. And we are doing an incision now. So this is a very easy lens for young surgeons and to prevent complications. And even for experienced surgeons, it is very easy to prevent these rotations. It is very simple, the surgery, very easy to fold and very easy to inject and very safe because it will not turn around. As for the results with the phakic EYECRYL, well, refractive, similar to ICL, very predictable with the calculator, no surprises, and we have a very quiet post-operative process, no rotations in our toric lenses. And as for the vault, no surprises, even in extreme cases, as a hypermetropic of 9 diopters. So we have a more stability of the vault in the post-operative care. Dr. Paredes said it already. Critical points that I don't like about this, the durability of the material. Biotech says that it will last 40 years, but my experience of that of more than 20 years, I have had no problems with the material. I believe them though. And it is another critical thing, the explantation. When we implant a phakic lens, we will have to explant it. And if it is more rigid, then it's going to be more difficult to explant. And the ICL that I have explanted is very easy to do. The lab is telling us, though, that it is very easy to do the explantation. And I've seen some videos and that it shows that it is very easy to explantate. So it is explanted very easily, and we have to take into account that the explantation, I like to do it with McPherson, and the longitudinal axis of the lens should be perpendicular to the incision, and then it is very easy to extract, even to 3 and 2, and it would be easier. Another critical point is the labeling, because the serial number is higher than the axis and the cylinder of the lens. So we are normally in the dark in the theater, and then you have to look for the axis, the angle, and the cylinder. And we've talked to the lab in Biotech Iberia, and they said that they are working on it. They are going to introduce the size of the lens, the sphere of the lens, the cylinder, and the size of the cylinder in bigger letters and in a more logic way. So to summarize it, what's what I like the best and the most? The security and the vault predictor is very reliable, and we have 4 different choices of the lens. So the implants are very safe, and also the stability of the implant. The lens is not rotate, and it's going to stay where we put it. So it means that the post-operative, it's very reliable, and also it is very easy to fold, very easy to handle. And this makes our life easier, and it is very reliable during the surgery, and also very predictable post-surgery period. We are going to be more relaxed during the surgery, and we can do a lot of bilateral cases. In the last 8 months, all my cases are bilateral because the recovery is very fast, and it is very easy, the surgery. And it is the best lens for young surgeons with no experience. And well, from Malaga, my best wishes, and have a fruitful marathon. And thank you very much for your attention. Thank you from Clínica Tirado in Malaga.
Dr. Tirado, we have him online. he has sent a video because he was traveling and he was not sure he would be able to connect online. Now he's live with us. We've heard Dr. Lamarca before. We have Dr. Cabanás as well. We're not, we're losing the sound. Okay, I don't have a lot, I don't have good signal here. I don't know if you would like to comment something on the video, because we could not hear you very well because of the music, so it was not very clear. We're losing the sound. We're losing the sound intermittently. So any comments? Well, basically the folding tips, it is easy, really easy to fold. We were always wary when we were implanting an ICL before, but now this is something from the past. And I have a peace of mind when I am implanting these lenses. The folding is very easy, and especially the surgical maneuvers or handling is if we allow the distal aptics to open, so there's no rotation. We have a question from the Netherlands. Dr. Van Hersel. I don't know if we have any questions here in the room as well. Good afternoon, Antonio. I have a couple of questions for you. Why do you perform a 3mm incision when the lens can fit a smaller incision? Well, it's for logistic reasons. I do everything 180 degrees, and we have the surgery packs, and we use the 3mm knife, and we haven't changed it. So you have mentioned the benefits of having a more rigid lens when handling it, and it is better, right? My question is, do you think this rigidity when implanting could be a factor to be considered to prevent trauma to the crystalline, something that may concern young surgeons or surgeons that haven't used these lenses before? Well, I think it's the other way around. If it's rigid, the handling is better inside the anterior chamber. When you push an ICL, it falls because of lack of rigidity, and you cannot push it wherever you want to place it. I've had cases of the iris closing during surgery. When implanting these lenses is easier than an ICL, because when there is mydriasis, an ICL is more complicated because when you have to push it, it's better when it's more rigid. If you handle it properly, the lens can be positioned much better than an ICL, and then you feel that when you place the lens, it doesn't rotate. Sometimes ICLs rotated, it changed the angle, I had to replace it, and it continued to move, and it was complicated to achieve the degrees you wanted. With an EYECRYL, where you put it is where it stays. And I used to hold it when I rinsed the chamber, but now I don't have to do it. I place it almost in the right place. I use my on the left side through a paracentesis. I place it in the almost the right position, and I don't have to move it. I barely have to move it. Thank you, Antonio. To be honest, the surgery, the procedure is much, much easier. I have a question. Precisely because of the material, which is easier to handle, sometimes I go straight to the sulcus to place it. Do you do it as well, or you prefer to place it on top of the iris and then? Yes, I do it. I put it in front because when it falls up, I try to prevent that it rotates. I wait until the distal haptics have opened, and I just wait until it is a bit open, and once they are open, I place them. Sometimes it fits under the iris directly when the chamber is bigger. But in general, I place it in the anterior chamber, and through the paracentesis, I push the haptics, first the proximal and then the distal, or sometimes the contralateral haptics. But patients stay in the clinic 2 hours, 2 hours and a half, and the eyes look like normal. We have a question by Dominic. We are friends. I couldn't pronounce your name, sorry. But one of the questions is, but you answered the question, the 3 millimeter question. So Dominic is asking, inverting the lens, sorry, and place it in a U-shaped position. Is it traumatic, or does it cause any issues? I believe he's asking about the folding marks. I don't get the question, because the lens is always folded in a U shape, and it opens in a U shape. If you open it in the opposite position, in an inverted U shape, I think that the question is concerns that some surgeons are not used to inverting the shape of the lens, and so would it cause any problem to invert it? Well, what we do, if you can see my hands, is we fold it like this, we inject it, and then it opens in the same position. This doesn't create any marks on the lens. There's no lines created on the lens because of that. And also using blunt tweezers, you wouldn't leave any mark on the lens. And a question for all of you. Do you use the lens rise as an input? Do you input the lens rise? Yes, it's absolutely necessary. You're using, all of you, right? Yes, it's compulsory. It's compulsory. So this removes all the problems and issues we used to have before. So thank you, Antonio, for talking to us. I know you were traveling, and it was you had to make an effort. Yes, I had parked my car in the wrong place. Thank you so much. Enjoy the event. Now we move on to Dr. Lamarca. He will speak about many things. So please, Jose, you have the floor. Thank you. This afternoon, we're going to share our experiences. And now with Dr. Tirado and myself, we're going to do something very similar. We're going to explain a nomogram we're doing with Biotech, with my colleague Carlos, which is achieving very correct results, very good results. The first thing we need to consider is that every one of us have different cases, and it's hard to have the same tools in our clinics. In some clinics, they can have one scanner, or ones have MS-39, others who are more focused on phakic lenses. We're going to use KCA2 device. That's good and well, but we need to have a useful tool which works with our devices. This is why Biotech has developed an algorithm that allows you to use different tools, different instruments. This algorithm is very powerful. It uses a lot of measurements. We have 6-eye measurements, architectural measurements, and there's a lot of work behind it, using AI and experience and optimization for each and every device, trying to avoid any volt issues and other problematic situations where we expect a certain volt size and then the result is different. We did a simple study with 36 eyes of 18 patients. Initially, this is the standard sample. If we create an algorithm, the sample needs to be standardized so that it is useful for everyone. And as you can see, the spheric powers and the cylindric powers are very average, which is what we were aiming at. In our clinic, we have different technologies. We have a Cassia 2, MS-39, OrbScan 2, and a Quantel ultrasound probe. For each of them, we have different measurements to characterize the ATA, the sulcus to sulcus, and the CLR. With this algorithm, we obtain a result which is in the top 5 if we compare with other validated formulas. So we know this algorithm works. The correlation we have observed with this algorithm is really, really good. Our study has as a strong point the use of an ultrasound probe, and this is why we just had 36 eyes at the beginning. And at the beginning, we saw a good correlation, 0.45, by simply measuring the sulcus. If we think logically, we might think that if we know the sulcus, there's no problem. Everything should go smoothly and we should achieve 100% effectiveness. But this is not the case. The effectiveness is not 100%, but on top of that, we need to have an algorithm like this one to have a strong correlation. If you only take the data of the sulcus to sulcus of the probe and you apply them to the algorithm, you get even a better correlation. Therefore, it is useful, and this preliminary work by Biotech helps a lot to increase our precision. If on top of that, apart from these sizes provided by the probe, we use the Cassia to MS39 or all the devices we have available, the power of correlation increases exponentially. It's 0.8. This is very good. This means that the algorithm is naturally working very well. We have continued investigating and improving the algorithms, especially regarding ultrasound probes, and we've been able to increase the power of correlation even more. As you can see, most of our patients we have analyzed, the vault we thought they would have was what we observed later. So the predictability compared to reality is very good. No surprises, no outliners. If we compare this algorithm with the rest of formulas, we would be at the top 2 of formulas evaluating this plus or minus 100 micron in volt. There are not a lot of cases longer than 1 year, but with time we will reach a very powerful figure of correlation to achieve better results. And if you add a polynomial multimodal analysis, we will have a better correlation still. Something else we have observed that has nothing to do with the ultrasound, but also the evaluation, the assessment of MS39 and Cassia 2, because we have both of these devices. And there's a controversy whether we should have used one or the other. But as we have seen that Cassia 2 offers a slightly higher correlation, especially when the measurements are made manually. Regardless of the instrument, you need to validate it and check that it works as expected. Luckily, we have excellent technicians that support us. They perform with precision, and they can guarantee that what we do is correct. Here we could think, why are we obtaining these good results? These are images. On the left, it's an EYECRYL and an ICL on the right. On first sight, we see that the EYECRYL has two cuts. This means that it is architecturally is different than the star one. In the case of the EYECRYL lens, on the posterior side, we can see a more homogeneous image. There are no weak points. There's a correct consistency. If to this we add this slight rigidity, this high rigidity, then the lens is going to move less, and the dynamic volt is going to be smaller than an ICL. An ICL have points where the lens can move, as you can observe. This is being researched, and this causes a bigger movement of the lens. So the idea by Biotech to edge both sides of the lens will have an impact, and this achieves better homogeneity regardless of the power of the lens. Sometimes there are huge differences, but the stability is much better than an ICL. Regarding the placing in the sulcus, we need to think why this happens. Why do we have these good figures? Is it the lens? Is it the calculator? Probably is both things, because the calculator gives us a situation where we can work with different devices and still have precision. But the lens is easy to work with, because what you expect is what you get. And this is due to basically two things. First, the optimized architecture, the shape, and the memory of the material. This helps to avoid hypervolts and 0 volts and have a much better predictability. Another of the things that we have studied to see how the ultrasound works and the sulcus as well is analyze the placement of the lens. These are images with Carlos. We did these ultrasound images. The results are interesting. So our ideal placement would be in this theoretical sulcus. Obviously, we can find issues. We may find cysts. We may find situations where the lens is not placed correctly. But this can be overcome easily because of the consistency of the lens. We have observed as well that we have a success rate of 64% regarding the ideal sulcus. We find situations where the optics are not placed correctly in 30% of the cases in the temporal area, and the transition zone where one side is well placed and the other not. This is 56%. But the analysis is curious, because it has shown that on the right eye, the nasal position is normally perfect, but on the left eye, we are much more effective on the temporal side. And this leads us to think what's going on, because it's curious. As we said, there might be special situations that change the outcome we expected in the sulcus, or maybe just a question of ergonomy of the surgeon. In the previous surgery we just saw, the incision was placed at 70. I can use my left hand, so I have no problem. We might not be as handy, but we all have our preferences. But I found out that maybe I have certain habits when placing a lens, regardless of the fact that I'm using my left or my right hands. I always use the side that's to my right, regardless of the eye. Therefore, it might seem logical that the success rate is better on the nasal side, on that eye, because it's the first that I place that goes to the sulcus, and the other one because the conditions are not the same, are not as effective. These are just hypotheses, and it's good because they teach us things. But of course, if we compare an EYECRYL lens with a star lens, and you can see a paper by Dr. Reinstein where we see that star lenses show more cases where the placement are not as good. Possibly the factors that have an impact are the memory of the material and the design. So I think the success rate depends on each surgeon, but we need to study this further. So to conclude, this first adjustment we did to the algorithm provided a a very good statistic power and predictability. We have many patients within this 100 micron range. Any deviations to the monogram have worked very well. And Cassia 2 appears to show a slightly better results compared to MS39. And obviously that Biotech calculator provides a very good ranking top within the top 2 in formulas. The more instruments we have, the more advantages we'll have in predicting the fold. This is what has been shown by research carried by ourselves and other hospitals. Ultrasounds is very promising. The lens go placed in the sulcus. We like to see what the sulcus looks like, and the new beta calculator is very promising, showing to be very promising, and we hope that in the future it will be released for everyone to use and have less complications, which is what at the end of the day we're looking for. So this is it. Thank you so much.
Thank you very much, Jose. We have a couple of questions from the audience. Well, having a look at your surgery with the OCT, how do you modify the size of the vault vis-a-vis the results? If there is an estimation of the change that we will have afterwards, if you measure it, if you in order to know that you are in the right vault. Well, we are using the intra-surgery OCT, and it is very useful, and we could stop and measure it, but it is something that we do not normally do. So when I was operating today, it was, for example, 200 microns, but very subjective. You are very close to the crystalline lens, and you can do it. And but we can definitely measure if we want to stop. And we estimate that we will have approximately 200 microns more. And do you modify the position of the lens during the surgery? Yes, absolutely. But I don't see a lot of surprises right now. With Vanessa, we talk about this. I have the provision. We are going to place it horizontally and otherwise vertically. And EYECRYL has something very good. And there are not a lot of hindrances in bringing you a vertical lens, a vertical position. And when you talk about the hastics and in sulcus, and sometimes they are not where they are. Well, they are touching the cellular body or behind. It is not something that we see, but and we work always behind the head of the patient, and it will be from 10 to 2, and we calculate the difference CX 0.2, and depending on the residual, the patient that we operated was in 0.19. So I try to get into the curved meridian. So I think it can be used in this type of lenses. With star lenses, you have to be more in the center. And I think that in these lenses, the rotation is the key. So we have a couple of questions from the audience. One for Dr. Carbonell. What made you change, and why do you Why don't you go back to the competitors? Oh, well, I already said so, and the speaker said so, because it is very user-friendly, it is very predictable, the volt, the calculator with the sizing of the lenses, and the support that you give us. Always ready to help. Thank you very much. For Dr. Lamarca, what is the importance of putting the lens on the sulcus and not on the ciliary body? Well, we have received some patients where there are curious situations. When we put a phakic lens, we think that the ferrula will stent anything. This is why we need to insist on the soft placement through rotation. We don't want to break the ferrula. And in some cases that we've seen of other lenses, in IPCL, for example, which was more rigid, we saw very low volt for the change of the size. So you had a low volt, you ordered a bigger lens, you placed it, and nothing happened. So the low volt was still there. So I think it can happen, but we need to prevent it. So the way we do the surgery is very important, and you have to be delicate. The EYECRYL lens, it is very easy to introduce. Depends on the experience of the surgeon. Sometimes you don't have experience, and when you manipulate the lens, maybe you break something. And I think it is safer even for the young surgeons. Thank you very much. There is another question that Dr. Cabanás has already answered about the 200 microns of increase of the volt. You already answered that. So just another question before Dr. Eguiza starts. For Dr. Lamarca, you said that you wanted to enter through the curve, but if there is no cylinder to correct, then what? Well, if we go more temporal, we are going to have less astigmatism. Refractive wise, we could enter through the neutral. And when we do a research, sometimes we always have to introduce it in the same spot. But with this, we try to use the curved meridian and in a peripheral area. But it depends on the surgeon and your need. And I wanted you to see the injector, but you don't have to expand it. The incision is in 3. Less, how much would that be? 2.7. But as I was saying, we are used to it. But someone who has starting, a young surgeon, maybe we can make the incision bigger. It has to be comfortable, and then little by little you can reduce the size of the incision. I think Dr. Eguiza has a lot of experience on that. So Dr. Eguiza, can you start your presentation? He is a surgeon of the ICQO in Bilbao, and he works with Anterion, and he will show his results with this platform. You have the floor. Thank you very much to Biotech for the invitation. I think that this 24-hour challenge is really interesting. I will talk about EYECRYL and the predictable volt and the angular change, I choose EYECRYL because of the good visual quality. It is very easy to handle and it is predictable. Sorry if I am repeating the same concepts that were mentioned by the other speakers. So myopia is a disease that is increasing, and we expect that in 2050, 740 million people will suffer from this. So we have to think about a treatment, how to correct it. And the phakic lens is being used a lot, laser less. And I think that with the EYECRYL lens, we will take more steps forward. And people who are scared, because we are talking about a healthy patient and we are introducing things in the eye, and I think that people will feel less scared about choosing it. Oh, and so why a phakic lens instead of a laser? Because it is reversible, the lens can be removed, it is effective, it is a very easy implantation, and the endothelium is very well preserved. It is not going to harm the endothelium, and it will not produce a hypertension. One of the advantages of EYECRYL is the central port, and that can be used in hypermetropy. So you don't have to do iridotomies, and then you have a good visual quality, and there will be no problems of hypertension. And it has a lot of sizes, and then your volt is going to be more predictable. As for refraction, the visual quality is very good in myopia and in hypermetropia, with a great visual quality. And then the injector, there was a video here. So we've been testing the new injector 2x2. The implantation is the same U shape. It is a very small incision, and as you can see, it is very stable, very easy, and it can be manipulated. So the incision is smaller, and it will not cause astigmatism in future. So it helps you prevent the astigmatism. And the volt is important. It is the distance of the lens and the crystalline lens. It is the most important indicator to know the size and the surgical position of the lens. So we want to have a specific volt, a specific amount of volt, and we don't want a cataract and we don't want to have a high volt because it can cause an acute glaucoma. Which are the variables that we have? The size of the lens, the diameter of the eye, and the crystalline lens dynamic. These are the different variables to know the volt. The advantage of Biotech is that we can introduce a lot of parameters, a lot of information, and we have an AI, and you can calculate the volt, and the results are better. And also the lens rise, that is very important to me. It will help us to have an exact volt. With our experience, with very high volt prediction, with the Biotech calculator, 300 micron, if we compare it to other calculators, it is very high and very certain. And this is why we have decided to use EYECRYL. In clinical cases, we have many that have the exact vault that was predicted. And why is it predictable, the vault? Well, because the calculator is very good. We have a lot of sizes to calculate the vault better, and also the material that can be introduced in the calculator. It is a rigid material, and it has not as much mobility. The other lenses are very good, but they don't take into account the flexibility of the material. This is why the volts are very high. So we are doing a research now that will be published shortly to see how the angle is narrowed. As long as the angles are preserved, everything is going to be okay. So we have to check the angle, and if the angle is mobilized or changed. So we made a comparative research with ICL lens, and we compared both lenses, the anterior and posterior angle before and after surgery. And we have checked the angle, doing a follow-up, and the results are very good. And in the EYECRYL it is less reduced. The iris will not be pushed, and having a more conservative angle will give you more safety. And you know that it's going to stay like this for many years. So to conclude, I think it is a very good lens, as we said. The calculator, the biocompatible material, no problems with cataract. So the material is good. It's a lot of sizes. It allows us to improve the vault, and also the dynamic behavior of the lens allows us to have a safer vault. And well, this is my question to you all. Now that you know that the EYECRYL lens is safer, it is very safe. Have you thought of implanting this in low or high myopias? Well, in my case, it would be interesting to know the levels of diopters, and doing refractive surgery, so laser. So from 5 diopters, then I will think about it. But it is an excellent option when we cannot do it. So we will have patients that with the 2 diopters, then you can do the surgery, the intervention, because the cornea is suspicious or something. Do you have a minimum limit? 5 up? Yes. But it is true that in very low myopia, if the pachymetry is very fine or other contradictions, then we have implanted phakic lenses of 1 diopter. Well, it depends on the situation of the eye, obviously, but with this lens, it is very safe, and it will allow us to take better care of the cornea. The pupil is an impediment to you, the pupillar size, using laser of a lens. Well, it can be a contraindication with big pupils, big treatments, and with LASIK surgeries, maybe you can go for bigger diameters. And maybe it is not as easy to do a diameter in a smile, but it's a good criteria. Another question from the audience. So for the three of you, if you've ever seen a difference in lattice photopsia in the central port, or well, regarding this photopsia, no, not really. Normally, we tell the patient about this photopsia, and sometimes they are too scared that they don't find it too cumbersome. No, nobody complains actually, and hypermetropics as well with this central port and the dysphotopsia. No, they don't complain. Yeah, I fully agree. And from Thailand, Dr. Chun Hakan. Well, sometimes you are scared of touching the endothelium, but you protect it, you don't touch it. It's very manageable, so no problem at all. And we don't have this way out that we could see with the ICL from STAR. It's a meva shaped. Here, it is a slow opening, and it is very important, though, the injector, the cartridge, so to invest time on that, so that the lens is well placed inside the cartridge and inside the injector. And also in the 18 cells after 1 year. Okay, so that's all. We close the scientific session. Thank you very much for your participation. We will continue with the surgical session now. We're going to have a coffee break. See you at 6. Thank you very much.
Hello again. Welcome back to this auditorium of the Barraquer Clinic in Barcelona. We will now continue with the surgery session with Dr. Sergio Eguiza. He will be presenting the session, and we will start the session with Dr. Laura Escudero. She was supposed to perform a live surgery, but due to force majeure reasons, the patient couldn't wait any longer. But we will see the operation, the recorded operation. We will see it in a minute, although it cannot be live. Laura is connected, and we will see the intervention with Dr. Escudero. It's a very interesting surgery. We're going to implant an EYECRYL lens with a Medicel 2.2 injector. This lens will be introduced with a 2.2 injector. I'm going to focus on my hands. We fill everything with VSS. We open the lens vial. It is a minus 9.5 diopter lens. We're going to apply the methyl cellulose in the cartridge as well. We fill it with methyl cellulose also on the tip, and with a Kelman pair of tweezers, we extract the lens. We can touch it because it is it's made of an acrylic material, and we fold it. We're going to see it through the microscope camera now. I am loading the lens with the Kelman tweezers in the cartridge. I just need to center it and press down on the center of the lens. I push and as I close the cartridge so that the lens is folded in the shape of a U. It's a concave U shape. I press until it clicks, and you then have to check that we see the first hole on the left. It's the opposite of other phakic lens. I move it to the tip, and I'm going to go back a little bit to make sure that the lens is not trapped, it's not obstructed. Now we're going to move to the eye at 2.2 scalpel. The main incision as well with the same tool. I used to use 2.75 knives to implant other phakic lenses, even 3.2, but it's enough with 2.2. I make it a bit wider to feel more comfortable, but you don't need it if you don't, it's not necessary. Intra-chamber anesthesia with lidocaine at 1%. I rinse with serum, and then we apply the methyl cellulose. I fill the chamber with methyl cellulose, and can I have the lens, please? I don't feel, I can't hear anything, so if you have any questions, we can see them later. Can I have the lens, please? And I'm going to use a spatula to hold it a little bit. You can feel some pressure. It is normal. Open the eye, the move, and we're going to implant the lens. It fits the opening of the cartridge through the incision, and the lens is going to unfold in the shape of a U. It is perfect. We just need to pay attention to the hole on the left. It's perfect. Miguel, thank you. The lens is implanted now, and when it unfolds, it's completely flat. It's impossible for it to turn around. I'm going to fill the chamber with a little bit more of methyl cellulose. Now we're going to push it under the iris. Sometimes you can fit it right under the iris, but if not, you can use this tool. You might feel a little bit of pressure. It is normal. We push down, and I think it is a lot easier to implant this acrylic lens because since it is a bit more rigid, it is easier to put it down, to put it under the iris, and you require less handling, less manipulation. Now it's perfect. Hold on, bear with us a little bit. And now we're going to aspirate the methyl cellulose. You will feel some pressure and water. Open your eyes. White, please. Also very important with these lenses, having a central port and hyper opaque lenses. You don't need to do an iridotomy. The lens is injected perfectly with the 2.2 injector, and I've been implanting them recently like this, and really being able to do a smaller incision using the very same injector I've been using for multifocal lenses. I think it is very versatile, convenient, and we're not closing the incisions. And this is the end of the surgery. Thank you. And I don't know if now or later you might have some, may ask some questions if you have any. Can I have the antibiotic? And we're done. Thank you. Miguel, we're done. Hello, Dr. Laura Escudero. And this was a near-life surgery. I just did it. It was supposed to be a live surgery. We couldn't do it, but thanks anyway for this beautiful surgery. We've seen the new injector. It worked very well. We also have Dr. Anton Barraquer, who is here with us as well. You are online with Dr. Barraquer and with Dr. Sergio Eguiza. Could you elaborate on the surgery? Would you like to highlight any aspects of it? Sorry, I couldn't follow the Congress because I was in the OR, but being able to implant the lens with the Medicel 2.2 injector, I don't know if there are other phakic lenses that could be implanted with this injector but in my opinion, it's very convenient. The lens itself is easier to implant than others, but on top of that, using the injector that works very well, the lens unfolds beautifully. You can predict the movement, and you don't have to make a big incision. Hello? I lost you? Hello? Is it working now? Yeah, sorry, we lost you for a minute. Sorry about that. Shall I speak? Yes, please. Finish your sentence. Well, I think it's a great development to be able to inject the lens with the Medicel injector. It's a 2.2 injector. We don't need bigger incisions. The lens goes in very smoothly. The unfolding is very predictable. The lens, nor the lens nor the incision is suffering, and I think it's a step forward compared to other lenses where you cannot use this kind of injectors. Go ahead, Anton. I have a question. I agree with you completely. Having a 2.2 injector makes a difference. But I have a question. Do you try to access through the curved meridian 90 degrees and the accompanying the haptics since the lens is horizontal, if we accompany them, if we work from a 90-degree angle, maybe it's easier to push them. Do you have that same feeling? Do you use the same technique? Well, I always go in temporarily. if the cylinder is bigger than 1 diopter, I'm going to implant a toric lens. So I use a temporal approach. With smaller cylinders, I use paired incisions, coupled incisions. With the new 2.2 incision, you're going to cause less astigmatism with your incision. So it doesn't really matter where you access the chamber from. So it is a great advantage. And because if you're going to have a bigger astigmatism, you might consider a different lens. So this is a great improvement using a 2.2 injector. It gives you flexibility, safe handling of the lens, even with small incisions that sometimes could cause the lens to rotate. But this one is very predictable. Yeah, this is precisely the advantage, the benefit of being able to use a 2.2 injector with such a small injector with a perilimbic access. You're not going to reduce astigmatism or generate astigmatism. So I'm not going to use a 90-degree angle when the easiest way is 180 degrees. Yes, I continue to use 3.0, so I haven't tried this injector yet. This is why I'm asking, and I'm sure this would change everything because working in a 90-degree angle is very uncomfortable. So I was making my question from a theoretical point of view, but with this new reality, things change. I don't know if you have any other remark or comment regarding the sizing, because there are many more sizes, and this is also interesting. Do you have any experience regarding extreme sizes? I don't have any, unfortunately. So could you comment on that? Yeah, personally, I have experience because just because I didn't follow the indications by Biotech, someone who had a very positive CLR, we didn't measure it, and now this patient has a volt of 30. The lens was 13.5. I exchanged the lens for 14 lens and later 14.5, and the volt continues to be 50. It's a curious case. The volt disappears, and for me the biggest size is 14.5 in my case, but you can customize a bigger size up to 15 by Biotech. In this case, maybe you could do the rotation vertically or find a different position and play a little bit with other sulcus positions, maybe. It was a toric lens. It's a patient with -7 or -4. The advantage with Biotech, with customized patients, we have a few of them here, it worked very well, and you can implant them vertically, even toric lenses, and that is a huge advantage, and it gives you better safety in the future. You can customize the lens, and that is an advantage. Interesting, thank you. We have a question for Dr. Barraquer. What is the reason why you always go in a 90-degree angle? Well, normally in cases with small toricities with ICLs is 90 degrees because the tendency is to go for the rule astigmatism. So since I'm using a 3.0 injector, I use this approach. Then the rotation and the movement of the haptics, if the instrument is perpendicular, maybe it's a small detail, it's not a big one. I could do it temporarily, of course. It can be done, we've seen it. But maybe it is easier to move the haptics, to push the haptics with this horizontal position of the lens. we have another question from Latin America. Do you have experience with phakic lenses with high myopia with a 3.0 injector? So they want to understand what happens with a thick lens. In this case, this surgery we've seen, it was 10 diopters of myopia minus 9.5. And after a month using this injector, this is the highest myopia we have corrected, 10 diopters. We don't have any more questions. Thank you, Dr. Escudero. I don't know if you have any questions in the panel. No? Thank you, Laura, for connecting and for the live surgery. Sorry for the problems that we couldn't see it in live, in real life, and but thank you anyway. We'll see you in here in the room. Okay.
We give the floor to Dr. Jose Lorenzo with a very interesting case, things that happen. Dr. Jorge Lorenzo. Hello. How are you? I'm good. Well, thank you very much to you and Carlos and the Biotech, and to explain that the surgery is not of very high quality because it is a surgery that was recorded. It was done 3 weeks ago when you got in touch to do this live surgery. So it is a surgery that gives another perspective, another insight. So it's not of a very high quality, but you can at least visualize it, and I think it can contribute to the discussion. Do you hear me? Yes? Can you hear me? Yes, yes, we are hearing you. Well, we have just started the video. Can we play it from the beginning? Okay. So it's a hypermetropic patient, 7 diopters, 2 cylinder. So all the phakic lenses, I dilate them with a mixture of lidocaine and epinephrine. And my colleagues use metal cellulose, but I prefer the radiosodic at 1.8%. The incision is of a 2.7, and it is a lens, as Laura said, where you can totally see the incision, and I had a 4 phakic lens on the day, and then I implanted it as it was an ICL, the other way around. And there is nothing impossible in medicine, as they say, but this lens, it is so rigid, and it is a benefit that it can be implanted upside down with that rotation of the lens inside the cartridge. This will never happen. It was because of me. The extraction is done with a Kelman tweezers. And it is one of the great advantages in case of a complication. The traditional ICL lenses, we would leave a mark, or we can even break them if you puncture them. So one of the big advantages of these lenses is this. So apart from the central port, that it's basic for me, a very important thing in the hypermetropic, we are loading it, and it is well placed, and now I am making sure that I am placing an EYECRYL, not an ICL, that it is rotated to the right. So in the moment of the implantation, it is not going to turn around. And as I said, this rigidity allows you to control the entry point. So it is not folded, and then you don't know it is not going to be open up. This happens with the ICL. In this case, it doesn't happen. It is a very soft deployment, and one of the advantages of the toric lenses is these marks, and the lens is completely placed. As Laura said, it is very easy to place it. The optical is more rigid, and the optics are very soft, so it is very easy to place. And I wash a little bit the viscoelastic with solution, and then I do a complete wash. And I normally put antibiotic and acetylcholine because I like the lens to be in the right position. I leave the patient during 20 minutes in the clinic, and then we measure the volt before they leave the clinic. Up to now, there have been no problems with the volt, with the EYECRYL lenses or the hypermetropic lenses. And when, as I said, it is a step forward, 2x2 placement. The rigid material is an advancement as well, is a development. The marks of the toric lenses every 30 degrees, and this means that it is less mobile, the lens. So it is my golden standard in phakic lenses. I've been using it for 2.5 years. And 1 week before you contacted me to participate, I had the first complication. I didn't realize it was the other way around. And this lens, if it had not been a toric lens, this patient would have gone home with the lens upside down. If the marks would have not been there, I would not have realized. Thank you very much, Jorge. It's been really interesting and very illustrative, and very good to talk about these mistakes that might arise. You will not be the first one, not the last one. And I think it's because of the patent, because all the lenses in the market have the marks on the other places because of patent issues. And now they are supposed to be open, the patents, though, Do you have any questions for Jorge? Well, do you dilate during the surgery? Well, I always do the dilation during the surgery. Well, it is this is what I do. It's not that it's good or bad, but I like the patient to go home with the pupil closed. And it is easier to contract it. And I don't see an advantage and I don't see a disadvantage in the patient coming to the clinic with a dilated pupil. I think the dilation is the same. And just because of this, it has no big benefits for the patient. Well, when we tested the cartridge 2x2, I made a mistake and I didn't do the U shape and then it was upside down. But it is important that it's better to remove it than turning it inside the eye. I had a very wide chamber, but I think it's always better to remove the lens and then mount it again, because you're afraid that it's going to break when you extract it. But I think it's always better to extract it, to remove it and not turning it inside the eye. I think it's better for the patient and for the cells. In 27 years that I've been using these phakic lenses, I've had 3 rotations, 2 in the implant, during the implant, and then this last one. The first time I turned it inside the eye, and then we lost endothelial cells. It was a young person with 3,000 cells, but almost 1,000 cells were lost. And it is something that you learn with the experience, and we never did it again. So I would never rotate it inside the eye. It is a mistake, as you say. And the second lens, an ICL, I was a little scared of breaking it because ICLs are softer and you are going to leave marks. You are prone to leave marks, and it is very elastic and it might break. So, and then the last case, the case that you've just seen, it was very easy to extract with the Kalman tweezers, no marks. And this would be the ideal. And it's happened to me, and I've published and I recognize my mistake. But I think that you need to focus on the surgery. If it happens, if it's rotated, you can extract it and turn it and inject it again. Yes, the material is perfect. You can see it in the video. I have 2 questions. Bolt wise, so you check it just after the surgery. So if the volt was not the expected one, what would you do? Would you wait? Would you operate again? And also the second question, your experience with the productivity of the volt. Well, I will start with the second question. The productivity is makes me feel very relaxed. I've been using this lens for 2.5 years, and we didn't have to change any lenses, so it's very predictable. more than the previous lenses. So it is one of the big advantages apart from the ones I've just mentioned. And regarding the first question, I measure the volt to prevent an excessive volt. So a volt of 4 would concern me. And a few years ago, I had a patient with an excessive volt that went home and came with hypertension. We tried to bring it down. We extracted the lens, and the pupil was reactive for the rest of his life. This is why we measure the volt after the surgery. And will not be able to change the size, but at least if I have an excessive volt, I would remove it straight away. I will not leave lens in a patient with a very excessive volt. Okay, very interesting. Well, thank you very much, Dr. Jorge Lorenzo. Thank you for coming to this meeting and for illustrating such a representative case with a personal mistake and something that can happen. And also the solutions to the problems. This is very important. So if this happens, it's fine. And then you can fix it, you extract it, and you can use the same lens. Thanks for your collaboration, for your time. Have a wonderful evening in Gijón. Thank you. I think Laura has a question. Laura. Oh, she's online. I am listening to her.
Opino como Jorge que un bolsero en...
Yes, and
Decía que yo
with,
opino como Jorge que un bolsero no nos da
agree
miedo
with
precisamente
Jorge
por el
that a
puerto
volt of
central.
0
El
is not
paciente que tengo
scary
medio
because of
que
the
realmente
central
por talla
port,
ya le tocaría un 15.
and a
El
patient
ángulo
that
está
would need a
abierto.
15, the angle is
Midiendo el volt
open.
realmente es de
So
30 o
measuring
40
the
micras.
volt from
Y sin
30 or 40
embargo, un
microns,
hipervolt me da mucho
but a
más miedo.
hypervolt would be more scary to me. So something I wanted to mention is that I've realized, and it happens with all patients, when we measure the volt after surgery, I normally try to operate in the morning to see the patients in the afternoon and don't send them home like what happened with that patient that I explained to you. So when I see them 3-4 hours after surgery, we see that the volt is a little higher than just after the surgery. They have 250 after surgery. In the afternoon, they will have 350. So the 100 micro more than after the surgery. So after the surgery, you leave them at the MOX, or all patients, I give them Edemox while they are waiting, half an hour waiting, and then I give them an Edemox. Although I think that there is no viscoelastic left, but I prefer to give them an Edemox.
Todos el protocolo les pongo una gota de Tobradex,
Yeah, this is the
Alfagan
protocol.
y Edemox.
Alphagran, Tobradex, and Ademox. That's my protocol. Well, we normally don't do it unless they have something in the clinic history. Maybe a Upimax in a specific time. But it is something to take into consideration. Any other questions? So thank you. Thank you, Dr. Laura Escudero, Dr. Jorge Lorenzo from Clínicas Baviera. Thank you for your collaboration, for your time. It's been a pleasure to have you in this first 24-hour marathon. And we hope to see you again in the next editions. Thank you very much. And now we go to Dr. Javier Clavel in Barcelona, who will show us a very interesting case of a substitution, a replacement of a lens. You have the floor, Dr. Clavel.
Can you hear me now? I was muted, sorry. Thank you for the invitation. I'm happy to show you my case. We have a presentation for this. Go ahead, Javier, please. Can you start? Can you launch the presentation? Next slide, please. Just say next slide, and that's all, and we'll move from one slide to the other. Well, I had a video also prepared. Yes, it is better if you can comment on the presentation, not the video. I'm going to present a case of a patient who had a cataract due to contact of the phakic lens, the old ones. He was 38 years old, and we'll see the evolution of the case. So, as I said, 38 years of age. He was operated 17 years ago. He was -12 myope. He had good acuity, but we observe a cortical cataract on his right eye. These are the OCTs we had during the exploration. You can see a contact in the peripheral area, a central vault between 80 and 90 microns, but on the sides we can see contact in both eyes. On the left eye, the cataract was very mild, almost imperceptible. And the question is, what do we do with such a young patient with cataracts due to a phakic lens? The first option is to continue in the nothing and do a cataract surgery, remove the phakic lens, and prescribe -12 glasses, which is not ideal for the patient. I would guess, recommend then that cataract is not at the end of the world, and it can continue until he loses vision, and the best option is to replace the phakic lens. In this case, we use the EYECRYL lens because of its properties. One of the reasons not to perform a cataract surgery is the detachment of the retina. We have a calculator, and the data show that the risk is above 4% a year. This is an acceptable risk for a patient so young. So The patient was not really convinced when I explained this, and he didn't undergo surgery. Later, he was referred with corneal infiltration. He had viral conjunctivitis. The lens was more or less the same. The vision of the right eye had worsened. And this is the exploration with the lamp. We see the cataract on the edges, and these are the tests we made before the intervention. These are the topographies. They are normal on the right eye. We can see on the anterior face a bit irregular. We had the infiltrations that were still active at the time. These are the endothelial counts, the OCT, everything all right. And the biometric data stands out the fact that the anterior chamber depth was smaller for such a patient. So it was 2.84. The left eye had a little bit more space. This is the video of the operation. This is the explantation surgery. Normally I make a bigger incision because you could cause endothelial damage otherwise. And the second thing is to inject viscoelastic under the lens to separate the lens from the crystalline lens to avoid damage to the lens, to the crystalline. Once we have separated the space, we use the haptics, move it to the anterior chamber. Some colleagues do this movement without using the haptics, but according to my experience is that you can damage the iris accidentally if you leave the lens in the interior chamber. We inject more viscoelastics to separate the lens from the endothelium, and then with the McPherson tweezers, we pull the lens and it goes out very easily. It's important to pull from the optic zone, or at least between the optic and the haptics, because otherwise the haptics could break. We put more viscoelastics and we implant the new EYECRYL lens. The EYECRYL lens is really easy to handle. The injector, the unfolding is very controlled, very symmetrical, everything correct. And once we have the lens in the anterior chamber, I always try to inject some viscoelastic to lower it down. We rotate it. These are the normal steps. We rotate it. We place it in the sulcus, and we just have to aspirate the viscoelastic solution, and the operation is finished. These are the post-op results. They were very good. The right eye improved vision to 2022. There was some refraction, and the left eye unity and refraction 0, 0. No endothelial damage, no damage to the crystalline lens, and the post-ops, the right eye, the result was 301 and 174 on the left eye. Let's see the OCT images. Sorry, first the slit lamp images. This is the right eye and the left eye. There's certain opacity, but it's not important. This is the comparison between the pre-op and the post-op volts. you can see that the volt is 174. There's no contact in the periphery. The lens follows the curvature of the crystalline, and this is the left eye with a smaller volt, but even so, there is no contact in the periphery. As a conclusion of the case, we know that lenses to correct high myopia have a higher posterior curvature. The central part is thicker, and this causes a more vaulted anatomy. The explanted lens has an intrinsic vault. This is a lens that is vaulted in the periphery, and this intrinsic vault needs to be added up to the anatomic vault of the patient. And this explains that sometimes we see reasonable central vaults. This was 80, 90 microns, but there's contact in the periphery nonetheless. The advantage of the EYECRYL lens is this flat profile with a more homogeneous intrinsic vault. There's not a drop in the vault in the periphery, and this contributes to it having less curvature. This is thanks to the material. The material is different from polymer lenses. The distribution of the power and the refraction index is different. This allows us to distribute the power differently and avoid an excessive curvature of the posterior side. In the design of the EYECRYL lens, the anterior side has certain refractive power. This contributes to a smaller curvature in the posterior side, and the fact that to a lower curvature of the lens as a whole. The dynamic vault is more stable, and the reason is because it is more rigid, and the movement of the pupillar movement is going to be less on the lens, and the vault is not to change so much due to this. And the last factor is its predictability. We know that the lens is in the sulcus. This means that the vault is more predictable, and there is less risk to have a contact with the crystalline. And this is more or less the case I wanted to present. I hope you liked it. Thank you, Dr. Clavel. It's been a very interesting case, a very creative solution from your part, and taking advantage of the benefits of the EYECRYL Phakic lens with very high efficiency, and at the same time achieving the objective, which is to increase the vault, which is 300 micron in one eye and almost 200 on the other eye. So as we saw from the pictures, it is a vault which allows the flow easily. There's no contact, so the case is solved. That's correct. We could have achieved bigger vaults, but the chamber was a bit compromised. It was 2.8, so not a lot of space to work with. And the benefit was this. I wish I could have achieved 300 on the left eye, but the anatomy on the periphery avoids the contact, so good news, very good news. Here the important thing is that thanks to the shape of the lens, we would have used a bigger size if we had continued to use the other brands, but with a smaller size, you prevent any contact and you stop the cataract. So I think it is a good way to solve this case, because on the other case, you would have used a bigger size and you would have still have some contact in the periphery. Yeah, maybe it could be a protocol, not a protocol, but maybe a common use practice for refractive surgeons. When we see contact on the periphery, when a patient has been operated many years ago, well, we could use an EYECRYL lens because we know that the posterior curvature is going to be respectful with the eyes. We have a question from Madrid. How did you know that this could work? There's a work by Dr. Paredes and Dr. Mora. Did you use this work by these doctors where they talk about the symmetry of the vault, or is it something that you have deduced from your experience? Well, this information came from you, really. When we went to the Biotech factory and all the technical information of the lens, I haven't had the opportunity to read the paper you just mentioned, but I just based my technique in the theory. You told me that the posterior side was not so curved, so I decided to try it. Thank you. We don't have any more questions here in the room, do we? Well, thank you so much. I know you're very busy today. Thank you for talking to us. And we're sorry to your patients because they are gonna be they are a bit delayed because of your participation. Tomorrow you will participate in the sessions in India, and also hello to Dr. Clavel. Bye-bye to Dr. Clavel from Clínica Baviera and Dr. Barraquer. Well, the scientific session is over now, and now we move on to a keynote that should have been at the beginning of the event, but we had to change it. I have to use a handheld microphone. Okay, I'm going to try the other one. Welcome once again to the first keynote, the first official keynote of this 24-hour event here at the Barraquer Clinic in Barcelona, Spain. We're fortunate to be, I'm going to use the handheld microphone. We're lucky because we've been able to carry out this project, this ambitious project where we're going to be more than 24 hours going around the world in this event. And what we want to achieve with this keynote, especially, is that this lens is an evolution. It's not, well, it is a lens that has been designed from scratch. It's not another iteration of another lens. This lens has been designed from scratch with a vision, which is to have the most efficient lens in the world, the most efficient phakic lens in the world. This ambitious project started 12 years ago. It is a project that is very alive, having a Phakic lens is a privilege for any brand, and for us is no exception, and this is why we're very happy about it. We started, as I told you, 12 years ago. This lens was patented. And why is it different? Why do we talk about rigidity? Why do we talk about a number of things that make it different? Well, it's not coincidence. This has been chosen this way. This lens is the way it is because we wanted to achieve this behavior from the lens. There are three keywords here: power, flexibility, and resilience. These three words can be applied to any model of a lens. But in our case, there are certain differences from other lenses where these three words mean a different thing. They are unique. They have a unique meaning, and they make this lens unique as well. So we work on the material. This was the first critical decision we had to make. What material to use? And we decided to use the best. And we used to use Benflex 26. It's a hydrophilic material. You know that phakic lenses in the market are hydrophilic, and with some exceptions, you can vary it slightly, but the basis is the same, with a higher or lower percentage of water. But the first thing we did was to choose the material, not only the best and most prestigious material with the longest history of implants in the world. We have almost 200,000 implants of phakic lenses, and this makes things easier because purity is important. It's important for many reasons. Having a purity of 98% with the smallest content of acid metacrylic acid is something to be highlighted. We've been talking about security, and this, in the end of the day, is what we're looking for our patients. We want security. This is the objective: safety and the best results, the best outcomes. This material, apart from this, it needs to have certain harmony in its surroundings, right? And here comes the architectonic design, the architecture of the lens, because this is what makes the material stable and gives it this intelligent, this smart memory. We call it smart memory because if something is smart, it's something that can act differently according to the scenarios. And we have created a lens that is able to react to a low volt by increasing it, and also to prevent hypervolt. So the architecture is designed to prevent both extreme situations. The material is important, but the surface is as important as the material. And here we have also worked from scratch, trying to achieve the best precision, making it smooth, making the surface smooth. When you talk to physicists, they tell you that photons don't understand about microns or kilometers or nanometers, and for a photon everything is enormous. And so the smoother the material, the less distortion of the light. And the roughness is the smallest that has been studied to date, if we haven't missed a recent paper. So the Atom microscope on the right, it's a simulation. It's very visible. It's a normal surface, and on the right, this is a photograph. The left one is a simulation, and the right is a photograph. This is the surface of our material in our lens, where you can observe at this scale the smoothness of the surface. This is very important to make the best use of energy. The least energy we use, because light it's not the same losing 2%, 3%, 5% on a more rougher surface than preserving as much as possible in percentage of light lost. So this is very important to improve the post-op scenario, having the best surface possible, and this was achieved by polishing it using cryogenic techniques up to -80 for certain products. It's a super sophisticated cryogenic treatment in line with the highest standards in the industry, the highest. And this allows us to be very precise when achieving the refractive predictability, the target. The error margin is probably the smallest in the industry. It's very more strict than the ISO standards, and this can only be achieved when you cut using very low temperatures. But as we've said many times this evening, this alone is not enough. It is a combination of quality of the lens, the material, the optic design, the architecture, and this together with a good calculator. We have talked about it a lot today. For us, the calculator is a very important project. We depend, many of our clients depend on it, and I am thankful to the speakers we've had today, because we have a very good collaboration with all of them. We're lucky to work closely with our physicians, and it is curious because sometimes when you analyze the situation of the industry, it is weird that we are working to offer the most precise solution, but we do it through a middleman, really, which is the surgeon. We don't work with the final client, and this is unique in our specialty. How do you do that? How can you be super perfect, super precise, and offer the best solutions for someone you're never going to meet? And there's only one way. The only way is to work together with surgeons and ophthalmologists. And this is how we have achieved the second version of our calculator with an AI engine integrated. It has been improved with machine learning. It also includes different algorithms, a multicentric algorithm based on European data sets. We also have a global algorithm. They are very similar, but there are certain optimizations in certain cases to predict the volt. As you know, in Europe, there's a tendency to use the CLR measurement, and this is why the European multicentric algorithm based on many centers I think we have 1,500 eyes included in this sample. It's a big sample for a phakic lens calculator. And if we go through the literature, I don't think we can find such a big sample. And this is thanks to this multicentric work that has been done in Europe. We have a very powerful engine, and to have a calculator that is leading the industry and leading this speciality. But this year we have important changes because the sulcus is very important, but it is something that's not widespread. It's better to measure it than estimate it, right? It is clear, and the UVM is being more and more used. It's very complex to interpret the results, and we're proud to be the first company in the industry that's able to offer a calculator where a surgeon can introduce a sulcus measurement. It's very complex to understand and to do. So this is thanks to the surgeons we work with. They have made things very easy, and we're starting to understand how we can add this valuable measurement in our calculations. And this year we can announce that since February this year, we have incorporated this measurement with very incredible results, as Dr. Lamarca explained earlier. These are unique results, especially from the point of view of a manufacturer. We're the only one who is providing this kind of tool. There are not many formulas in the world that include the possibility to measure the sulcus with UVM and integrate it in a calculator. But in our case, the calculator is multimodal and can be combined with other measurements, very reliable measurements, and this way provide better robustness to any calculation. UVM is operator dependent, and this is part of the complexity. It's difficult to interpret. It depends on the machine. There are machines with better resolution than others where you can see this better. And this makes things complicated, or at least surgeons find it difficult to integrate this value. We are improving this, we are simplifying it, and we've been able to offer a tool that is really very powerful, with including this measurement. Of course, we could predict the volt based on CLR, but the same happened with white-to-whites and ATA. The more you use, the better. Obviously, it's the same with CLR. And we cannot... we think that one measurement is not enough, and this is why we spent a couple of years comparing two measurements. Some centers have two CLRs, and they can use these measurements to increase the safety, and the calculator is prepared to spot a difference, and it warns you that maybe you should repeat the OCTs, you should repeat the test and see if the patient requires any extra adjustment in the pre-op of the patient. We have created this system where you can introduce two CLR measurements at the same time to multiply the safety of the calculation. Regarding versatility, we can say that this calculator is the most versatile there is. There's no other calculator that can integrate 23 different devices, and some of them also allow several measurements at the same time. For example, wide-to-wide, ATA, spur, and CLR. So it's 4, really. So in this case, versatility is undoubtedly a reason to position ourselves as at the top of the industry. We also mentioned that when we want to rotate a lens in hyperopes, far-sighted patients, we know that when there is a high volt, and this happens, typically when you have spherical lenses, you could rotate it, but to avoid an iridotomy, you have a limitation. Having a central port, the surgeon is free to play with the position of the lens and try to improve the volt without jeopardizing the stability of the intraocular pressure. And something we are also offering this year is freedom when choosing the sizes. This is the end of one size fits all. So far, or until now, all the calculators, well, not all, but almost all of them in the industry work like this. We offered one size, and this was supposed to be the good one, but this was a concern for experienced surgeons because they know when to go one size down, and this was a limitation because the calculation would give you a bigger size, but the surgeon would choose to change it. Now they can, but with the calculator, with the Biotech calculator, the surgeon or the operator can choose different sizes and see in situ the prediction of the volt with that size. They can adjust the size, and the volt prediction is going to change with this adjustment. By clicking on the lens, because there's a marker that comes from the architecture of the lens, and the calculator, until you choose the exact power or the model of the lens, it cannot give you an exact volt calculation, because depending on the power, the volt can change because of the architecture. Belief we've had until now is that the lens should move as little as possible inside the eye, because we believe that it is more stable. We have given it better memory to reach the sulcus, because this implies less rotation and better stability in all respects. It's not a lens that is compressed from the aptics in, and that it moves forward is different from a lens that is well supported on the sulcus with better stability, right? So one of the benefits of this, of a well-placed lens, or a lens well-placed in the sulcus, is that typically the dynamic volt is smaller. This is something we have been analyzing since the beginning, and we think that having a smaller dynamic volt gives you better stability and creates a smaller turnover within the eye, because the aqueous mass inside the lens, behind the lens, because we've been many years calculating that the aqueous mass behind the lens, when the pupil closes and the lens goes back, this mass that moves from behind to the anterior chamber for a dynamic volt of 200 microns equals 400 times what the eye can produce in that very same second. So we don't think that the smaller the turnover, we can maintain the equilibrium. With the smallest dynamic volt, more naturally it's going to survive within the environment because the eye is peaceful. So this turnover of the aqueous flow is not normal. So in this respect, we are proud with our project that you will hear about it soon, because there are clients that are working to develop a method that allows us to better understand what's going on inside the eye. I cannot tell you more about it, but soon you'll have more news. But I'm proud to announce that in our case, we are reducing around 45–50% the turnover inside the eye. And this is because we have half the dynamic volt. The dynamic volt has been reduced by half. And the jet effect that moves the aqueous towards the endothelium needs to be more healthy if the dynamic volt is smaller. We've seen the cell counts, 18 cells of difference after 1 year. And yesterday, the presenter and former patient, Chantel, did a review, and she had more cells, which is impossible, but it means that it has not been reduced. This is clear. There are no more. They analyzed a different area. Obviously, having a bigger count means that there is no reduction after 3 years. So the endothelial health has something to do with it. Of course, the hands of the surgeon make a difference. Always, we know that, because an experienced surgeon in the use of phakic lenses is essential. So the endothelial preservation for us has been one of our objectives by reducing the flow rate from 18 nanoliters to 9 or 10 nanoliters per second. Here we see an example of an EYECRYL lens. In this case, the anterior side is, you can see a concave curvature. This means this is a lens with a cylinder, and the cylinder coincides probably with the horizontal axis of the lens. This is why you see a lens that's very flat. And the dynamic volt is very low, is 150 to 100 microns. Sometimes there are cases where the dynamic volt is very high, because this not only depends on the lens, it depends on the iris mass, the size of the pupil. There are many things that have an impact, but in general, we have almost half the dynamic volt than other lenses. We've been working in the presbyopia EYECRYL lens project. We are enjoying this project very much. We'll hear about it soon, about the ideas behind this project, and we believe that we have many arguments to succeed, to be successful with this presbyopic lens. These are more complex eyes, so we must not rush in this project, but we're receiving very good feedback with patients between 40 and 50 years of age, and we are learning from them. We are receiving very good advice from them, and we believe that's going to be a game changer when it is ready, and we hope it's going to be very soon. So I would like to let you know, many of you know it already, that we wish to, well, we aspire to have the best presbyopic phakic lens in the industry. We have different areas of innovation. We have the materials, purer materials with the best surface quality, with the best architecture, with the best behavior and performance. Secondly, the second challenge was the calculation of the lens. The calculator is essential to make the most of its potential. You can have all the resources in the world, but if you don't have a precise calculator, it's not going to be very useful, is it? So, thirdly, having freedom of choice, being able to implant the lenses vertically, being able to choose the size or the machine you have in your office. This is very powerful, and at the level of hardware, we have integrated at least 9 new devices, some of them with more than one value, more than one width measurement. So it's a total of 15 measurements in this 2.0 version of the calculator. But in terms of physiology, we are also proud to be able to offer a lens that can coexist in very smoothly in the surgery environment. We don't want the lens to move very much, right? This is our objective. So we need to be able to adapt. The lens needs to be able to adapt to the changes of the eye, because the eye is alive and the lens has to have this plasticity, this adaptability. But this adaptability, this movement needs to be just right. It needs to reach the sulcus. It needs to have the smallest dynamic volt to reduce the turnover. It has to have certain features that keep the typical issues related to a high hypervolt or a low volt, in order to preserve the normality and the health of the eye, and the sizes as well. In the last 4 years, or almost 5 years, we've been preparing the calculator, which we believe that right now is the best in class, and that is offering what many physicians have been wishing to have for many years now. So this is my keynote. Thank you so much for your attention. I don't know if there are any questions. We don't have any questions. So this is the Spanish session, and so I would like to thank one by one all the physicians.
And also Clinica Barraquer for welcoming us to their auditorium as hosts of this marathon. So thank you to Dr. Antonio Tirado, Dr. Margarita Cabanás, Dr. José Lamarca, Dr. Pablo Morales, Dr. Eguiza, Dr. Anton Barraquer, Dr. Marc Carbonell, and in live surgeries, thanks to Dr. José Lamarca for his surgery, Dr. Laura Escudero, Dr. Jorge Lorenzo with the video, and Dr. Javier Clavel with this very interesting case. I think I've mentioned to everyone, thanks for accompanying us in this first edition of the marathon. We hope to see you in the next edition, and we close the connection until 9 Spanish time, 8 in Morocco, where our presenter, Chantal Pretorius, will start the connection. Thank you. Thank you very much to you all.